Ms Wilkinson.
Milady, the Care Quality Commission wish to thank you and your team for the obvious care and attention paid to the important evidence heard in this module, and wish to assure the inquiry that they too have followed the evidence attentively. CQC acknowledges the observations of many witnesses about the impact of decisions made during the pandemic and their varied experiences of CQC over that period. It has become clear that a number of themes have emerged from the evidence, and I will wish to address you briefly on 3 of them, with expansion in written submissions to follow. Those 3 matters are the pausing of routine inspections, discharge guidance from hospitals, and contingency planning. First, pausing routine inspections and what should happen in future. It's important to note the qualitative difference between routine inspections and inspections prompted by intelligence regarding a risk of harm. To quote from Helen Waitley's summary, she said, "A care home or care provider was only going to be inspected every so often anyway to do their rating as to whether they are good or requires improvement. And it might make sense in the future, as it did in this, to deprioritise doing those because those aren't triggered by a particular concern about the care home. And everything's going to be different probably in the care setting during a pandemic anyway. So are you even going to get a fair sense of how you should be rating a care provider in that circumstance?" However, risk-based inspections of the kind referred to earlier by the TUC differ and are critical in ensuring safe care, and these were never paused. CQC would invite the inquiry to conclude that at the time in March 2020, as regards routine inspections, the competing interests were the need to ensure that the public received safe care whilst not exposing the vulnerable in those care homes to the virus being introduced by an inspector crossing the threshold without adequate PPE, testing or vaccination. The clear mandate at that time to those not designated as frontline workers, as CQC inspectors were not, was to stay at home because the risk of death to the vulnerable was too great and it was not known how long that threat would persist. Amongst the many witnesses from whom this module has heard, there was Ms Gillian Baranxi from Care Inspector at Wales, whose evidence on this same point as the Welsh regulator was, it is suggested, powerful. She said, "The thought of our inspectors taking COVID into a care home of which we were the regulators, and we know how vulnerable many of the people who live in our care homes are, that just seemed unacceptable." One might test the merit of that decision to pause by imagining the very criticisms that might now be faced by regulators in this inquiry if they had continued their routine inspections without adequate PPE and could be traced, just as care worker movement has been, as one of the key sources that introduced COVID-19 into care homes. This balance in favour of a pause was canvassed with and understood by relevant stakeholders and ultimately endorsed by government. Indeed, the inquiry will recall the very clear evidence from the then Secretary of State, Mr Hancock, which was for the CQC to pull back more than they were currently planning on inspections and data collection to reduce the administrative burden on providers of social care. He told the inquiry that he considered the consequences of pausing inspections to be a balance, and that's the challenge. Often in policy, especially in these terrible times, we were taking actions in order to preserve life. CQC understands and accepts that to some providers and users of services, it would have felt different, as many things did during the pandemic. But CQC does not accept that it is a fair characterisation to say it abandoned the adult social care sector, went AWOL, or withdrew its oversight. From mid-March 2020 onwards, CQC gathered information to carry out its duties in the following ways. Inspectors made proactive telephone calls to providers in their portfolios, which triggered further action from CQC where a provider was not coping, and that did include the virtual meetings and online meetings that were called in those times management review meetings, and it did include in-person inspections. Between the 4th of May and the 29th of October 2020, there were 11,935 ESF calls with care home providers within the sector, and an additional 6,281 to domiciliary care providers. Intelligence was also gathered from provider collaboration reviews from July 2020 and the Give Feedback on Care form on the CQC website, which received 138,000 comments between March 2020 and June 2022. Emails and telephone calls raising concerns, including whistleblowing, were another source. All this information was logged on the Customer Relationship Management System and reviewed by the National Customer Service Centre. It marked a 50% increase in contacts from the public and 55% increase from people working in the services. In addition, large sample groups of providers received targeted IPC inspections. So whilst there may not have been the same sights, sounds and smells available, there was a sound body of intelligence to understand, prioritise and target risk. And in this way, CQC maintained oversight during the pandemic. For the future, however, my lady, lessons have been learned. And as this inquiry is aware, there is ongoing transformation within CQC. Whilst it will always be for government to determine how best to protect public health, depending on a future pandemic's transmission route, CQC recognises that there would need to be the widest toolkit available to enable regulation to continue. This could include and should include a robust registration system, broad intelligence gathering methods, but also CQC has said and maintains it is committed to the recommendation it made in its written evidence to recognise the importance of on-site inspections and to ensure the ability to continue to conduct them in a future pandemic. Secondly, discharge from hospitals to care homes and future guidance drafting. CQC did not draft the COVID-19 hospital discharge service requirements that the Department of Health and Social Care issued on the 19th of March 2020. When the department sought CQC's agreement to suspend entirely the requirement for trusted assessment before a patient was discharged from hospital, CQC refused to agree. Mary Cridge explained that this was because CQC will always put safety first, and the trusted assessors must take account of the legal responsibilities of the social care providers, who must ask themselves, can they care for this person safely? CQC's only engagement in the full document was to ensure that the content of Annex C, the trusted assessor guidance, remained as unaltered as possible, changing only to require that the NHS employ and use more trusted assessors. Going forward, CQC's position on drafting this sort of guidance is as stated by Mary Cridge. Our position on current powers on guidance are confined to guidance about compliance and how to meet the fundamental standards. It doesn't go wider than that. We think government are the best place to provide guidance in a pandemic. What we need is guidance that is relevant to social care and is not health sector guidance adjusted for social care. It's a very diverse sector with lots of different sized providers. The best way to really good guidance is to have that genuinely co-produced with those who provide services, those who receive services, and the various experts. CQC has a role in that, perhaps even as a lead facilitator. But I think, she said, CQC providing guidance about guidance, that's not a healthy state. It's the road to confusion for providers. And finally, my lady, contingency planning and the CQC's role in future preparedness. At present, the regulations by which CQC must exercise their oversight do not presently require any provider or local authority to hold a pandemic plan. What was required both in 2020 and remains the position today is that when a care home registers with CQC, they are told they may be asked to supply some additional documents, which, depending on the type of service they plan to provide, may include a business continuity plan and an emergency plan. To date, there has not been a definition that emergency plans must include pandemic plans. As was clarified during Joanna Killian's evidence, the aim of a pandemic plan differs from that of a business continuity and business contingency plan. She said that it falls to national government to define the threats to the nation, which range from flu pandemics to cyber attacks. It then falls to the Local Resilience Forum to make sure that the local authorities within their footprint are ready to respond to a national emergency. A business continuity plan is a mechanism to make sure that business can continue in the event of a cyber attack or similar threat such as a flood. It is with this evidence in mind that the recollection of Helen Whately should be viewed when she was referred to a WhatsApp message dated the 3rd of March 2020, stating in relation to an Essex Local Authority contingency plan that providers are required by CQC to have plans in place to provide safe care in the event of a pandemic. She suggested that she would expect CQC to be the natural organisation to oversee plans held by providers or local authorities, given the new powers to inspect. But CQC is not qualified to risk assess what amounts to an adequate pandemic plan for a care provider. Indeed, its work in oversight of local authorities is limited to their duties under Part 1 of the Care Act. It is, however, expected that setting the criteria for adequate pandemic plans will be part of the government's current work, referenced by Michelle Dyson as the Pandemic Preparedness Strategy to tackle the 5 different potential transmission routes. And CQC can confirm that it is one of the organisations which has been invited to be, quotes, around the table in this planning work. And CQC stands ready to play whatever part is deemed necessary as a result of that process and this inquiry's recommendations for the future. Lady, those are those 3 matters highlighted by CQC at this stage.
Thank you very much, Ms Wilkinson. Mr Wright.
Good afternoon, my lady. I'm here on behalf of the United Kingdom Health Security Agency, or UKHSA, as I will refer to it going forward. My lady, at the start of these hearings, you rightly described the impact of the pandemic on the adult social care sector as devastating. The complexity of the sector presents challenges, but what must be remembered is that those it is intended to support are often the most vulnerable among us. It's vital, therefore, that we all continue to learn and implement lessons for the future. As your ladyship has heard, UKHSA, like Public Health England before it, has a discrete role to play in supporting the sector. That operational role encompasses surveillance of pathogens and infectious outbreaks, contributing public health advice to national guidance published by government departments, and producing IPC guidance. And at local level, UKHSA's health protection teams offer specialised support. UKHSA does not have policy oversight for the sector, nor is it a regulator of it. Our corporate witness statement and our opening statement set out UKHSA's reflections as to what, having regard to the agency's role, could be better done to support the sector for a future pandemic. I want, therefore, today to address 2 matters. The first has been a central issue in this module, and that is the impact of hospital discharge decision of March 2020 on infection rates in care homes. And the second is the production of guidance. To turn to the first, discharging an individual who no longer needs to be in hospital has long been seen as best practice and continues to be so. There are good clinical reasons for this. But it meant, for example, that even prior to the pandemic, guidance existed for the discharge to a care home of a patient who had flu symptoms or had been diagnosed with a flu infection. It's not in dispute that Public Health England was not consulted on the policy decision to free up NHS bed capacity and only became aware of it when it was announced on the 17th of March 2020. You've heard evidence for the rationale for that policy decision, including from the former Secretary of State for Health and Social Care. He spoke of concerns that hospitals were, quote, likely to be overwhelmed, end quote. And as Mr. Hancock explained, the policy decision was made at a time when it was recognised that there was limited testing capacity. The consequence was that Public Health England and others worked at pace to produce what has been called, in this module, the April admissions guidance published on the 2nd of April 2020. This was consensus guidance coordinated by DHSC and to which the NHS, CQC and Public Health England contributed. It preceded the announcement on the 15th of April 2020 that all symptomatic care home residents and staff would be offered a PCR test. It has been argued that hospital discharge was the predominant route by which COVID-19 reached care homes, particularly in those early months of the pandemic. The inquiry is very familiar with the technical report published by the Chief Medical Officer, and Professor Laura Shallcross, who undertook the Vivaldi 1 study at the invitation of Professor Susan Hopkins, then Incident Director for Public Health England, drew your attention to a schematic in the technical report, which set out 7 potential routes of ingress for COVID-19 into care homes. You will have noted that the authors of that part of the technical report came from UKHSA. The technical report, citing various research studies, paints a more nuanced picture of ingress. It was why Professor Shallcross could make the point that there was a dynamic component to the contribution of different routes, depending on, for example, the time point of the pandemic. The list of relevant studies begins with Easter 6 in April 2020 and continues with other studies conducted in 2021 and 2022. We intend to address the findings of those studies in our written closing statement, but your ladyship may find that they offer the best evidence as to the contribution of different routes, including hospital discharge, to infection rates in care homes. When considering those studies, it is useful to keep in mind the following. First, the need to have regard to the intended purpose of a particular study. Second, the extent to which a study identified its own limitations, including as to what data was then available. And third, the need to take care when comparing different studies done at different points in time. Stepping back, however, what the studies do show is that hospital discharge does not appear to have been the dominant route of ingress, that there was a correlation between care home outbreaks and rates of community transmission, and that staff living in the community and moving between care homes unintentionally was an important route of ingress. And looking to the future, consideration of what is a complex issue cannot be seen as a simple binary choice between hospital discharge on one hand and movement and staff on the other. The 2025 National Risk Register identifies a respiratory pathogen as the most likely cause of a future pandemic affecting the UK. It would undermine effective pandemic planning if a particular route of ingress into care homes were not given proper examination. So, of course, the impact that hospital discharge could have in a future pandemic needs to be prepared for. However, as your ladyship has heard, that staff will work in more than one care setting is a long-established feature of the sector. And to ignore, therefore, the possibility that staff movement could make a contribution to infection spread in a future pandemic is to undermine the need to look at practical measures that may mitigate that risk. As with support payments for those isolating, such measures are not within UKHSA's gift, but they do need to be given thought. Could that mitigation involve, for example, supplementing incomes in a time of emergency so that staff do not need to move? And if that measure is adopted, then how do you plan for sufficient staff members across all settings? My lady, wider points have also been made about the role of DHSC and Public Health England in relation to data. It's been suggested by reference to the Vivaldi study that there was a cultural reluctance to share data, that there were occasions when the utility of Vivaldi was ignored by some, whilst this data was also being presented by others as their own. Professor Hopkins told you of the importance that Public Health England and UKHSA place on being able to conduct and publish research independent of government, and of the ethical standards expected of their scientists, and which those scientists expect of themselves. That's not to ignore, as Professor Hopkins acknowledged, that some things could have been progressed faster. But the inquiry is aware, across all modules, of the numerous studies that Public Health England produced and shared during the pandemic. The difficulties in getting PHE data into the NHS Foundry, managed by NHS Digital, was the example canvassed with witnesses. And it will be for you to decide if those difficulties were reflective of a culture or flowed from the practical need to ensure that there was appropriate measures in place to allow for lawful data sharing, as well as the infrastructure to transfer data safely. UKHSA's corporate statement addresses how Public Health England and then UKHSA collated and used data. The agency has never suggested that the infrastructure in place before the pandemic was as effective as it could have been. The evidence is that data sharing improved rapidly during the pandemic. However, as your ladyship is aware, UKHSA has in more than one module argued that building better data systems and addressing associated governance issues is key to pandemic preparedness. Professor Hopkins pointed out that much has returned to pre-pandemic baselines. And yet, not every change requires significant financial resource or the creation of a bespoke system. As Professor Hopkins explained to you, it remains the case that the fact that someone is living in a care home is not automatically recorded in GP records. The workaround adopted during the pandemic was to use postcodes. Moving to a situation where this simple detail is recorded, something which might, we acknowledge, need regulation, would prove valuable. And as to the use of Vivaldi data, Professor Shallcross's evidence was that, quote, absolutely everybody was very receptive to the information we were putting out, end quote. As Michelle Dyson pointed out, Vivaldi was an important study which provided robust and independent validation of steps, including in relation to staff movement, that DHSC was already taking. My lady, to turn briefly to the question of guidance, the expectation is that in a future pandemic, UKHSA would continue to fulfil the role it has in the production of national guidance. The guidance produced for the adult social care sector during the pandemic drew upon that which existed before the pandemic. It reflected the need to have guidance which could be adapted to different care settings. It is ultimately those providing care who have the best understanding of a particular setting and of the needs of those that they look after. They are best placed to undertake the risk assessment, which is a necessary step to implementing national guidance and should be seen as such. And in doing that, the oversight shown by DHSC, as well as the operational work undertaken by CQC and the Health and Safety Executive and Directors of Public Health in peacetime, will be critical to assisting different care settings. UKHSA's corporate witness statement has set out how the agency now interacts with the sector, including with care providers, and particularly through the work of its dedicated ASC team. Learning from the pandemic has been embedded and is being embedded. However, UKHSA recognises that more work can be done to ensure that guidance continues to be directed towards specific components of the adult social care sector, reflecting the different ways that care can be provided. Further, guidance is always better for a stronger evidence base. Whilst research funders such as UK Research and Innovation and the National Institute for Health and Care Research cannot fund all areas where research is needed, UKHSA can contribute by highlighting key evidence gaps to those funders to consider when determining funding priorities. And finally, an important lesson from the pandemic is the need to find ways to listen to the direct experiences of those who use the care sector, as well as family and friends, and then to use those experiences to inform the production of guidance. My lady, those are the submissions for UKHSA. Thank you very much.
Thank you very much, Mr. Rat. Mr. Khalik, I think you are. Find you.
Here, yes. Good afternoon, Pryn Hound Dar, my lady. My lady, the Welsh Government has listened very carefully to the evidence and reflected on the concerns of the core participants and the bereaved families. Full written submissions will, of course, be provided later, but I make the following brief submissions to address a number of key areas. First, it is important to be clear about the Welsh Government's role in the social care sector. The Welsh Government, as you've heard before, sets national policy and legislation, whereas day-to-day responsibility for managing and delivering adult social care in care homes and domiciliary care falls to the 22 local authorities who also commission services and also to the care providers. The Welsh Government does not have operational control in this area, and that is an important distinction. Second, on hospital discharge, Vaughan Gething, in his evidence, explained that the discharge framework dated the 13th of March 2020 was underpinned by the need to manage the risk that Wales as a whole was facing at that time of the potentially catastrophic collapse of the health and social care system. If action was not taken to try and ease the pressure of hospital capacity at that time. In this and in all other decisions during the pandemic, as noted by Mr. Gething, the Welsh Government considered the balance of harms inherent in one decision as against the alternative. Decisions had to be taken at pace and were based on, to quote Mr. Gething's words, the best understanding of the scientific and medical evidence available at the time. You also heard from Albert Heaney. He accepted that with the benefit of hindsight, it would have been better to test upon discharge from the beginning of the discharge framework being in place, but that approach was not in the scientific or medical advice at the time. And you will recall that the Welsh Government accepted in opening that between the 15th and 29th of April 2020, there was a delay between the decision to require negative tests before admission to a care home being made and the communication of this decision to health boards and the publication of the updated guidance. This was acknowledged by Mr. Gething and Mr. Heaney in their oral evidence. Third, on asymptomatic testing. Mr. Gething confirmed in his evidence that decisions on asymptomatic testing were similarly based on the scientific advice available at the time and not based on testing capacity. However, you heard from Mr. Gething that had the advice to engage in asymptomatic testing come earlier, the reality is that the government would have faced the very practical challenge of delivery and how to prioritise the tests available. In May 2020, targeted asymptomatic testing was introduced in care homes. General asymptomatic testing in care homes was not introduced before the 16th of May because the advice received up to that point by the Welsh Government was that the scientific evidence did not support it. You also heard in evidence that the advice relating to asymptomatic testing of all care home residents that was referred to by Matt Hancock in a health ministers' meeting on the 5th of May 2020 was never shared with the Welsh Government at any level, nor were its contents reflected in SAGE advice at that time. Fourth, on visiting restrictions. My lady, the Welsh Government always sought to strike a careful balance between preventing the spread of COVID-19 and the significant risks to vulnerable care home residents and staff, and the need to promote the well-being of those residents. Mr. Gething reflected in evidence that in hindsight, the Welsh Government could have progressed to permitting low-risk visiting sooner, but at the time, again, the scientific evidence and knowledge was not there to support this. The inquiry has also heard there were many iterations of the care home visiting guidance in which restrictions were adjusted to reflect a developing and evolving understanding of the virus. You heard from Gillian Boransky. She told the inquiry that the guidance sought to achieve this difficult balance, and Care Inspectorate Wales delivered seminars to aid the understanding of the guidance and risk assessment. The Welsh Government and the Inspectorate sought to ensure stakeholder groups and the needs of people with specific vulnerabilities, including those with learning disabilities, were recognised in that guidance. Mr. Heaney confirmed that the Welsh Government did not endorse a blanket ban approach to visiting and took prompt and appropriate action when it became apparent that some local authorities or care providers had introduced blanket bans at a local level. In recognition of the benefits of social contact and wider well-being, the Welsh Government sought to approach the issue innovatively and successfully rolled out the Visiting Pod scheme, enabling safe visits to take place outdoors, and promoted the use of video technology via device loan scheme. Fifth, on inspections in care homes. The decision to pause routine inspections was taken in March 2020 amidst a rapidly emerging picture of COVID-19 and was made due to the very real risk of inspectors bringing the virus into care homes to a vulnerable cohort of residents. As Ms. Boransky recognised in her evidence, inspections are a powerful tool in the regulatory framework, but they are only one of a number of ways in which assurance is and was provided within the social care system. You heard from Ms. Boransky that despite the temporary pause, inspectors continued to monitor and follow up on notifications, concerns, and safeguarding incidents, and services that were already on the enforcement pathway to ensure quality and safety of care. Although inspections were paused, my lady, Care Inspectorate Wales intensified its scrutiny and monitoring of services. A series of check-in calls with providers were introduced from 30th of March 2020, which performed a supportive function for providers and was a further source of information for the Inspectorate. Finally, on PPE, the inquiry has heard evidence that PPE supplies did not run out at a national level in Wales, but challenges were experienced in the very early months of the pandemic due to distribution difficulties at a local level. As Mr. Gething explained, about 2/3 of the care sector PPE needs were met by NHS Wales Shared Services Partnership by the 7th of May 2020, with the remainder being met by other sources. In terms of learning in this area, Mr. Gething reflected that in the event of a future pandemic, the Welsh Government should immediately progress to an NHS Wales Shared Services Partnership-led procurement of PPE for the care sector, as this model worked very well once established. Overall, and to conclude, throughout the pandemic, the Welsh Government was committed to protecting the people living and working in the care sector and balancing the protection of the health and well-being of recipients of care and the need to save lives. My lady, the Welsh Government is very grateful for the opportunity to assist the inquiry. Thank you.
Thank you very much indeed, Ms. Clegg. Now, Mr. Mitchell.
Thank you, my lady. This is the closing statement on behalf of the Scottish Government. I appear today along with Junior Counsel Julie McKinlay, and we are instructed by Caroline Beattie and Heather Auld of the Scottish Government Legal Directorate. To begin where this module began, and indeed where it ended, that is with the impact evidence, the poignant testimonies could not fail to move. This form of participation in the inquiry process shows a bravery that a non-looker may not fully understand, and that we who regularly appear in courtrooms perhaps come to take for granted. The Scottish Government pays tribute to those who participated in the film and who gave evidence. It passes its sympathies and its condolences to the bereaved across the UK. It acknowledges the Herculean efforts of the workforce, including the unpaid carers, who looked after our most vulnerable. As Ms. Freeman said, their response was absolutely exemplary. Today we examine some of the issues that arose in evidence to which we can offer some context and clarity. In Scotland, adult social care was prioritised in the pandemic response alongside the NHS. The Scottish Government did have a good understanding of the sector. There existed a wealth and breadth of specialist knowledge. Policy officials, professional advisors, and advisory groups all contributed to keeping ministers fully informed. Prior to the pandemic, there was extensive, meaningful engagement and consultation with the sector. During the pandemic, it intensified. The evidence would suggest that stakeholders accept this to be so. As Ms. Freeman observed, Scottish Care was a key and critical voice. Ms. Lamb noted that a broad cross-section of stakeholder voices was listened to, albeit those voices were not always in agreement. Turning to the decision to discharge patients into care homes, Ms. Freeman pointed out that decisions made by the Scottish Government were not binary, but were decisions between levels of risk. In March of 2020, delayed discharge had to be effectively tackled. We stressed the following points. First, the discharge of a patient from hospital is a clinical decision over which the Scottish Government has no control. Second, the Scottish Government cannot and did not compel care providers to accept admissions from hospitals. It did ask local authorities to put additional effort into reducing delays in discharging those assessed as clinically fit. Third, from the outset, great efforts were made to ensure that the process of discharge was conducted safely, through guidance directed at social distancing, clinical screening and periods of isolation. Testing prior to admission was introduced just as soon as capacity existed. Fourth, not all patients were discharged into care homes. Fifth, hospital discharges were not the dominant route by which the virus entered care homes. Analysis has revealed ingress of infections to be primarily attributable to staff footfall and directly related to care home size. The Scottish Government submits that the decision to discharge reflected a considered approach to a long-standing issue. It required to be taken amidst an urgent, rapidly developing situation. While protective measures at this time were, as Ms Freeman acknowledged, perhaps not fully adequate, they were the only measures available to us at that point. The alternative was to leave someone ready for discharge in hospital, which was a high-risk environment. Looking now at infection prevention and control, the principles of sound IPC practice have long been recognised in Scotland. Since 2012, Scotland has published a National Infection Prevention and Control Manual. It contains standard precautions. It was and continues to be applicable to all staff in all care settings at all times, in respect of all patients and service users. Whether infection is known to be present or not, it ought to have been well known to the care sector, although, as Ms Freeman recognised, training and delivery were not consistent. On 12 March 2020, HPS issued guidance specific to the social care sector. On 13 March, that guidance was supplemented with standalone clinical guidance for care homes issued by Scotland's Chief Medical Officer, and that was updated on the 26th March and 15th of May. Early in the pandemic, understanding of the virus and its effects developed rapidly. Guidance existed for the well-being and safety of individuals. There was a clear need for updates as new data and evidence emerged. Whilst recognising that it was challenging for care homes to respond to changing guidance, it was essential that it be updated and at speed. A few brief words on PPE. Concerns were raised in evidence as to its availability, yet it is important to remember pre-pandemic arrangements for its supply and the speed with which the Scottish Government and partners responded to increased demand. As the inquiry heard in Module 5, when in March 2020 concerns were raised, swift action was taken to support the sector. The Module 5 evidence suggested that, by the latter half of April, concerns about PPE supply in care homes had subsided. Considering funding and sick pay, the inquiry heard evidence about what is said to be the negative effect of fiscal austerity in the sector. However, in contrast to some other parts of the United Kingdom, since 2009-2010, expenditure on ASC in Scotland increased in real terms by 7% in total and by 5% per capita. In 2020-21, Scottish integration authorities received funding of £561 million for COVID-19 and £712 million the following year. This was in addition to wider social care support, such as reducing delayed discharges, loss of income and staff costs. On 12 May 2020, an initial £50 million in sustainability payments was announced, with a further £50 million on the 3rd of November 2020. In relation to sick pay, some social care staff were reluctant to be tested, for fear that a positive test would lead to self-isolation, a reliance on SSP, and a reduction in income. In June of 2020, the Scottish Government put in place a social care staff support fund to ensure that social care workers absent from work due to coronavirus or self-isolation received an amount similar to their usual salary. Further, in July 2020, it introduced a death in service scheme. A one-off payment of £60,000 was available to a named survivor of any social care worker who died without death in service cover as part of their contracted pension arrangements. Both measures had retrospective effect. Thinking now about visiting. The inquiry heard powerful evidence of the effect that visiting restrictions had on care home residents and their families. Yet, as Ms Freeman noted, decisions in this area highlighted that the entire experience of the pandemic concerned the balance of harms. There was no situation at any point where a decision could be made that carried no harm. The Care Reform Scotland Bill, promoted by the Scottish Government, received royal assent on the 22nd of this month. Amongst other provisions, the Act imposes a duty on Scottish ministers to require providers of care home services for adults to facilitate certain visits. Those provisions are known as Anne's Law, in memory of Anne Duke, whose family was unable to see her for extended periods during the pandemic. The Act strengthens residents' rights, allowing them to identify at least one essential care supporter. This will help ensure that supporters can continue their role even in infectious outbreak situations, when visiting is paused for others. That the Scottish Government introduced Anne's Law is recognition that families and friends play an essential part in the health and well-being of residents, and that the care home is their home. Turning to information and advice for unpaid carers. Access to information was a key issue for them and for local carer support services. Carers needed advice on how to protect the person they were caring for. That person was often at higher risk. Carers also felt an added responsibility to protect themselves from infection, both to reduce risk of transmission to the person in their care and so that they might continue to provide that care. In March of 2020, the Scottish Government created pages on its website to help people and carer organisations find the most up-to-date information. It created similar pages for young carers on the Young Scot Young Carers platform, covering a range of practical issues, including infection control and PPE. Finally, turning to regulation. The Scottish Government was aware of concerns raised by the public regarding both pausing and resumption of care home inspections. From the 13th of March 2020, the Care Inspectorate paused physical inspections due to potential risks posed to care home residents and staff and to Care Inspectorate staff. On 17th April, following a deep dive meeting on care homes and a resolution that the Care Inspectorate should reinstate inspection visits, the Scottish Government requested that directors of public health take immediate action to ensure an enhanced system of assurance. That is, by working with the Care Inspectorate, local IPC teams, primary care teams and others to oversee the provision of local support and assurance to care homes. As Ms Freeman made plain in evidence, the Scottish Government wished to see inspections resume, albeit in a manner that balanced potential risks. Decisions to perform in-person inspections were informed by individual risk assessments of each home under the clinical direction of directors of public health. This allowed considerations such as quality of care in each home to be taken into account. My lady, we conclude by, on behalf of the Scottish Government, once again passing sincere condolences and sympathies to those who have lost loved ones and to those who continue to suffer, and by once again acknowledging the efforts and sacrifices of our workforce during the pandemic. Before I sit down, I would like, on behalf of the Scottish Government, to extend our thanks to the inquiry for the work that has gone into this module. Those thanks, of course, go to everyone involved, the legal teams, the ushers, witness support and RTS, and of course to you, my lady, for your continued chairing of this inquiry. Thank you.
Thank you, Mr Mitchell. Mr Allen.
Yes. My lady, good afternoon. And as you know, I represent both the Local Government Association and the Welsh Local Government Association. Before I start, may I just echo what Mr Mitchell has said about our thanks generally to the inquiry teams. He put it very eloquently, and I can't find better words than he used. So thank you on behalf of my two associations. Both are very grateful to the inquiry for the opportunity for their chief executives to give oral evidence in this module. And both will have more to say in due course in their written closing statements. Today, I shall only summarise shortly some key points that they wish to make orally and at the conclusion of the hearing part of the module. There are some common general points. My lady, you know, for their part, both those associations aim and have the aim to ensure that the delivery of the best possible adult social care is done by their member authorities. You know how both are concerned to help local government, to help people from all walks of life to live their lives to the best, and that they will undertake that work in another emergency to the best of their ability, building on the experience of the last and the wisdom that will emerge from your report on this module. They are both fully aware, as you now will be, of the mental, physical, financial, logistical constraints of this pandemic for the provision of ASC. While every aspect of care at such times is more cumbersome and dangerous, both associations and their members know the essential importance of effective, humane and thoughtful engagement. You've heard how, despite the many problems of lack of PPE, of difficulties over testing and vaccination, and in the face of sometimes confusing and contradictory advice, those connected with the adult social care sector, whether in England or Wales, worked tirelessly and diligently. And you've heard also how this sector is not well understood, and how too often, particularly in the early phases of the pandemic, local government stepped up even though government in London and Cardiff did not act as fast or as well perhaps as it should have. And you have heard also of the many awful situations in which the pandemic took the lives of those receiving or giving adult social care despite the sector's best efforts. Their bereaved families carried the weight of this trauma, and both associations repeat their fullest sympathies to all those thus affected. Now, my lady, focusing on some points particularly relating to the LGA, the association fears that the country is still not addressing the fissures in adult social care provision that have been so exposed during the pandemic and by the hearing in this module. We are simply no closer, even in these peace times, to a sustainable and thriving sector, or a national understanding of social care's inherent value, or ensuring care recipients can always live as they wish. There is now a fear in the sector that the focus on improving adult social care is on the back burner, while yet another NHS reorganisation is underway. And that is why this module is so important. There are 4 points for immediate urgent action which sit alongside the recommendations in Joanna Killian's witness statement, which need to be made orally and now. First, we need sustainable funding and meaningful reform that is co-designed with all involved. You've heard the Casey Commission is on the horizon, but that multi-year process is no substitute for action now. Addressing deficits in resources and capacity that this module has exposed, system changes, and for both emergency and normal times are absolutely necessary now. Second, government, Whitehall and the NHS must work closely and regularly with the adult social care sector to ensure that policy translates to feasible and desirable practice. Local government must be an equal and trusted partner in planning for and responding to emergencies. And that means better involvement for local government in this autumn's pandemic preparedness test exercise Pegasus. It means engagement with all pandemic planning with senior LGA representation at relevant COBRA meetings. And it means co-design and co-production of all relevant guidance, both in respect of pre-pandemic planning and any new guidance that might be required during the next pandemic as and when it occurs. Third, more work needs to be done to work out the very best way to balance steps to keep people safe whilst enabling them to see their loved ones and their loved ones to connect with them, and allowing them to be assured of the care recipient's well-being. This is not an easy issue. It involves looking again at issues such as the content of Care Act easements, of visiting restrictions, and also decisions to suspend CQC's routine inspections. Central advice and guidance must be fully aware of the multiplicity of different physical care settings and must enable local flexibility. And lastly, for the LGA, it wishes to reiterate with emphasis that adult social care must have parity of esteem with the NHS, both ordinarily and even more importantly in a future health emergency. As a minimum, this requires a mandatory cross-Whitehall and NHS programme of induction for new and existing senior civil servants and officials whose departments have an interface with the adult care and support sector, to increase understanding of adult social care's operational and policy imperatives. Now, my lady, changing my focus to the Welsh Local Government Association, it notes and agrees with these points insofar as they're relevant to Wales. But it wishes me to present orally three points of critical importance in Wales, which sit alongside the longer and detailed recommendations in the witness statement of its Chief Executive, Chris Llewellyn. Well, first, the Welsh Local Government Association also emphasises the LGA's last point about parity of esteem with the NHS. In a pandemic, the health and social care sectors are equally important, and they are truly interdependent. They must be treated as such in all matters of policy and operation, whether testing, PPE, financial support, or public health control and easements. And this must not be seen as some mere chimerical aspiration. The evidence from the Care Inspectorate Wales, from Care Forum Wales, and ADSS Cymru was equally to the same effect. The mantra in future must be protect health and care equally. And government policy and action must follow through on this aim. It is essential this happens. Second, despite the evidence to the contrary from the former Minister for Health and Social Services, Vaughan Gething, any assumption that social care settings are safer than hospitals must be rejected as a fallacious generalisation. No future policy should be built on this assumption. Policy must be built on the recognition of the many and varied constraints on delivering residential care, the dangers of home care, and the dangers arising from a peripatetic and part-time workforce. Obviously, this requires a deeper look at discharge policies. Third, again echoing points made by the LGA, the WLGA emphasises the importance of investing in the workforce. It is not enough for the Chief Social Care Officer for Wales, Albert Heaney, to have noted how the system is very fragile, with problems of high turnover of staff and a very low-paid workforce. It is obvious that such fragility, if continued, will cost lives in a future pandemic. So the WLGA emphasise this is the time for urgent, meaningful action to improve the resilience and quality of the social care sector and to rebuild public confidence. My lady, the associations thank you yet again for your attention, and they will flesh out their submissions in writing and submit them in due course.
Thank you for your help, Mr. Drummond. And lastly, Mr. Stober.
Thank you, my lady. Can you hear me?
Yes.
I represent the Association of Adult Social Care Services. My lady, may I apologise for my phone going off early on today, even though it was completely switched off. ADAS welcomed the opportunity to contribute as core participant in this Module 6. They were anxious to acknowledge the sorrow of the bereaved and those needing and working in social care who were traumatised by the experience or who still suffer long COVID, to pay tribute to unpaid carers, to the committed care staff, and to mark the very significant efforts everyone who worked excessively long hours, days and nights over months without break. My lady, you've heard with remarkable consistency from witnesses that what happened to people needing and working in social care was both tragic in terms of the lives lost or compromised, but you have also heard evidence of remarkable demonstration of commitment, courage, and the best of human nature. In relation to better and timely planning for a future pandemic, ADAS has the following 5 recommendations which they would like the inquiry to consider reflecting in the recommendations of the final report of this module. First, a thorough review of the infrastructure needed at every level, national, regional, and local, such that social care and our social and psychological needs are addressed in a pandemic alongside the clinical and hospital focus. That means ensuring that there is regular social care advice to scientists and government at the highest level alongside the NHS from the people with operational as well as policy experience. It means a review of the local resilience forum and the NHS arrangements and accountabilities and what the best mechanisms are for planning and responding in the case of a national care and health emergency. 2, the creation of a national mechanism that could take the form of a reserved task force to be stood up annually so as to continually review and assess readiness and fit test plans. It should cover the work of the same advisory groups as that of the task force that Sir David Pearson chaired in 2020. It should review the recommendations made by each of those advisory groups, be informed by and draw on regional perspectives, for example, the ADAS regional chairs, be ready to stand up at the earliest indication of a future pandemic. Central government should be required to act on the recommendations of such a task force with relevant partners to ensure that social care leadership and workforce are trained and equipped to deal with a pandemic. This would include the identification of those needing and working in care and effective mechanisms for shielding, vaccination, testing, PPE provision, data, professionalisation, pay and sick pay, access to healthcare, mental health support, access to care, support and safeguards, such that we're all better protected, connected and valued. 3, serious consideration should be given to increasing awareness, recognition and valuing of social care through embedding very operational experience and social care personnel in government with cross-government recognition and mandatory induction delivered by leaders in social care field for DHS's civil servants and politicians with briefs in social care and the NHS, and also for people working in senior roles in the NHS. 4, a thorough revision of the discharge to access practice to include greater focus on integrated intermediate care, namely the care, treatment and supports offered to people, so as to avoid the need for hospital admission and to enable people discharged from hospital supports to recover, rehabilitate, and if long-term care is needed, to weigh up the benefits, risks, and costs of their option. 5, ADAS would recommend quality, safety, and safeguarding are integral to planning for and responding to a pandemic, given that people needing and working in care and support may once again be behind closed doors and home or in closed institutions. Finally, my lady, there is a collective hope that the inquiry will make a mark in recognizing just how essential social care is for all our lives and to start to build a new social contract about how we live, work and care for each other. Thank you, my lady.
Thank you very much indeed, Ms. Dover. Ms. Kerry.
My lady, may I just conclude these hearings by inviting you to publish an additional 70 statements later. I won't read all of them, but up on screen now are going to be the names, indeed the reference numbers and a description of the people that are all, and indeed the organisations that provide the statements to us. They include from local government, interest groups, the Northern Irish Health and Social Care Trusts, politicians, the COSLA survey, and indeed some remaining impact witnesses. May I finally just say this, a few words of thanks from me. Many of the core participants have been kind enough to commend the inquiry for the smooth running of this module. As I think your ladyship knows, but others may not, those words of thanks go not just to counsel and the solicitors, but to the paralegals, the secretariat, the operations team, and to all the other staff, security here at Dorland House, who have looked after us so very well. I truly am grateful.
Thank you very much indeed, Ms Carey. And can I add to that list, I entirely echo what you said, can I add our very patient stenographer,
Indeed.
who's had to cope with a lot of very difficult evidence.
Indeed.
Thank you very much. That completes the hearings into Module 6, the care sector. It's been an intense and at times difficult 5 weeks. I've heard some powerful evidence and some powerful advocacy. And from the very first moment I met the bereaved during my consultation on the terms of reference, and I went around the United Kingdom, I learned just how important this module would be to so many. I hope that those who have suffered so much agree that we have conducted a thorough inquiry and investigation into the most important issues. I certainly believe that we have. And as Ms Carey said, we've done it with the assistance of so many people. Obviously, the inquiry team, the witnesses, the material providers, the core participants, everybody involved in putting on hearings here, and the core participants' representatives, many of whom have provided substantial insight, and I'm extremely grateful to everybody. If I could be forgiven the repetition, I will now be considering all the material, the oral evidence, the written material, and of course any written closing submissions that the core participants may submit. I'm afraid we've had to restrict their time for oral submissions, but there'll be no restrictions on the length of their written submissions. I understand the need for urgency in publishing my findings and recommendations, and we'll do the best that we can, but everyone, I'm afraid, must remember that the report writing for this module in itself would take some time if we are to get things right. And in any event, the inquiry team as a whole, we're already working on several reports. But I do undertake that we will publish the report as soon as we possibly can. And I've very much taken on board the point that as worthwhile as Baroness Casey's review will be, it's going to come sometime in the future, or the results of it will come sometime in the future. So thanking everybody for all their assistance. I will now declare these hearings at an end. The next evidential hearings for Module 8, Children and Young People, will begin on the 29th of September. Thank you all very much indeed.